Now, the most recent updated guidelines recommend that if the patient has, if the male has a CHA2DS2-VASc score of 2 or more and a female has a 3 or more, there is a recommendation to give anticoagulation to reduce the risk of stroke. Now, we have to balance that against the risk of bleeding. The problem with the bleeding risk, so the has-bled risk it shares a lot of factors with the CHA2DS2-VASc score. So the higher the CHA2DS2-VASc, the higher the has-bled risk. So that's really a challenge in our daily practice. And we know from published data that patients' compliance to anticoagulation is really a challenge. And it actually peaks at around 50%, even with the higher CHA2DS2-VASc score. Even with the introduction of DUACs, that 50% went up to 60%. So we still have a gap of around 40% of patients who are not getting the appropriate therapy to reduce the risk of stroke. These are the list of the pivotal clinical trials that got all the DUACs approved. And as you can see, even in that situation where clinical trials are being well monitored, the discontinuation of the drug goes anywhere between 20 up to 35%. So it's really a challenge in managing of our patients. Now, another problem that we face with oral especially with DUACs, is giving a reduced dose DUACs, and that represents around 40% of the patient receiving DUACs. The problem with that, if it's not given for a renal impairment reason, studies have shown that there is a significant risk of stroke in those patients who are receiving a reduced dose of DUACs compared to the conventional dosing, without a difference in the risk of bleeding. So these are the day-to-day challenges that we are facing with anticoagulation. Now, the good thing about left atrial appendage occluder is that it's a one-time implant. It happens in the cath lab, minimally invasive, under GA, and the usual procedure time is around 1 hour, and the patient stays for 24 hours in the hospital. I'm not going to talk about the device in depth, but this is the WATCHMAN Flex, which is a major development from the first generation, where it is fully recapturable and repositionable before release. It has a reduced metal exposure, and as you can see here, the size between 14 up to 31. Now, the most recent platform we have is the Flex Pro, which increased the device size up to 40, and it's coated with Hemocoat, which facilitate the endothelialization. As a result, it gave us more options in terms of anti-thrombotic agents. Now, these are the options we have: oral anticoagulation plus aspirin for 45 days, followed by DABT for 6 months, then aspirin after that. The option 2 is DABT for 6 months, then followed by aspirin only. And the option 3 is basically like option 1, but without the aspirin in addition to oral anticoagulation. We know that WATCHMAN is the most studied left atrial appendage occluder. We have almost 20 years of experience from clinical trials and from real-world data. We have more than 500,000 patients had this device implanted in them over this period. Now, this is just to compare patients who are untreated with anticoagulation, or patients with AFib who are untreated with their annual risk of stroke. And you can see that the continuous line is the warfarin, and all the studies that looked at WATCHMAN device, actually it outperformed warfarin in hard outcome. How we select patients: these are the classic selection. So patient non-valvular AFib who has an increased risk of stroke based on CHA2DS2-VASc score, who is suitable for short-term anticoagulation therapy but deemed unable to take long-term oral anticoagulant, and a patient has an appropriate rationale to seek a non-pharmacologic alternative. Every time when we look at our patients in daily practice, we look at those who are bleeders, but we need to expand that lens and look at the others. Look at the patients who may have drug interaction with whatever medications that they are requiring for their medical comorbidities. In addition to patients who are at a future bleeder risk, non-compliant patients, also those who have issues with their lifestyle and they prefer to have therapy. So I always like to urge you to think about patients who, when you consider them for left atrial appendage occluder, is to look first for their CHA2DS2-VASc score. A male of 2 and a female of 3. If that's the cutoff reached, then is the patient suitable for anticoagulation? If yes, the patient has appropriate rationale to seek non-pharmacologic therapy? And if that's the case, then proceed for WATCHMAN device. And now, not all patients at high risk bleed, they're the bleeder, the high risk bleeding. You need to keep that in mind when we screen patients for WATCHMAN. With that, I finish, actually, exactly on time.